Hi everyone, I am Asha Creary and I am back with another episode of Post Grad with Asha, the National Counselor NCE mini-series. So in today's video, we are going to do practice questions in relation to Section 2 of the National Counselor exam. And Section 2 is intake assessment and diagnosis. So who am I again? Of course, I'm Asha Creary. I am a licensed professional counselor in the state of Texas and an approved licensed professional counselor supervisor in the state of Missouri. I am an educator, a mentor, and a clinic director. So again, I am not a supervisor in the state of Texas, but I intend to be at some point in January of 2024. So let's get into this section of practice questions. Intake assessment and diagnosis. This section encompasses the counselor's knowledge, skills, and abilities to effectively conduct client intake, assessments, and diagnosis. On the exam, you should be able to conduct a biopsychosocial interview, conduct a diagnostic interview, cultural formulation interview, initial interview, and determine diagnosis. You should be able to perform a mental status exam, consider co-occurring diagnosis, determine level of care needed, assess the presenting problem and level of distress, evaluate an individual's level of mental health functioning, screen clients for appropriate services, select, use, and interpret appropriate assessment instruments, use formal and informal observations, assess for trauma, assess substance use, obtain client self-reports, evaluate interactional dynamics, conduct ongoing assessments for at-risk behaviors, including suicide, homicidal, self, or other injury and relationship violence, use pre-test and post-test measures to assess outcomes, evaluate counseling effectiveness. So this section is only worth 12% of the test or 19 score items on the test. Let's get into the first question. Which of the following set of information is a part of the biopsychosocial interview? A, presenting problem, precipitating factors, predisposing factors, and protective factors. B, presenting problem, precipitating factors, perpetuating factors, predisposing factors, and protective factors. C, presenting problems, precipitating factors, perpetuating factors, and predisposing factors. Section D, presenting problem, perpetuating factors, predisposing factors, and protective factors. Give you a little bit to answer that. And the answer is going to be B as in boy. So all of these factors need to be a part of the biopsychosocial interview. So remember, bio, psych, social. Biological components, psychological components, and social components. Biological components, which would probably include some presenting problems, but it'll more so be like family history, different things like that, or even history of genetic disorders that could be impacting mental health. Psych, of course, what are the things triggering your client? And then social is what are the social dynamics, cultural things that are included in that client's day-to-day. And again, all of these things need to be present when you're doing a biopsychosocial interview. Next question, question number 2. A 12-year-old patient came in with a history of behavioral issues and shares that they are unaware of the reasons in which they do the things they do. They shared that they cannot control their behaviors. The therapist then begins to ask the client information regarding when the behaviors began, what the behavioral triggers are, discuss changes in symptoms over time, and obtained additional background information. Which of the following describes what the therapist is doing? A, a biopsychosocial interview. B, a diagnostic interview. C, an initial intake session. Or D, none of the above. All right, the answer is going to be B, a diagnostic interview. So again, there were no questions about biological, psychological, and social components. So it's not a biopsychosocial. It's not the initial intake necessarily. I mean, that could be a correct answer, but this didn't describe whether or not this was their first session or if this was like a follow-up session after something happened over the weekend. We don't know that information. So then it would be a diagnostic interview. So if the client is unaware of why they are doing something, your job is to find out why based on the symptomology, the history, the triggers, and changes over time, and any other additional background information that is going to help you diagnose what's happening with this client. All right. A 25-year-old Black patient comes in with the symptoms of grandiosity, decreased need for sleep, and more talkative than usual. The therapist's original diagnosis aligns with bipolar 1 disorder. But prior to making a final diagnosis, the therapist asks additional questions around the increased self-esteem, the pressure to keep working, thus resulting in the need for less sleep, and continued motivational interviewing around the excitement of this new venture. The therapists discuss where they learned how to turn their pain into passion and why it is important to hold confidence when things are not fully on track. What is the therapist doing? Is it a biopsychosocial interview? Is it a diagnosis? Is it gathering additional information prior to making formal diagnosis? Is it a cultural formulation interview? It is a cultural formulation interview. For example, it is a Black client who came in with grandiosity, the decreased need for sleep, and more talkative than usual. Normally, a physician or a therapist there will probably be more symptoms connected to this under bipolar 1, but most clinicians will have just slapped bipolar on there. But if you understand the culture of Black clients, you understand that grandiosity is something that we're learned as kids. We're learned to have pride and have high self-esteem when it comes to trying to accelerate in life or in regard to us as individuals. They're not sleeping because they're trying to meet this goal if you pay attention to what they mentioned. So they're trying to meet this goal and they're not sleeping. And then the therapist continue to ask questions around, well, what's the motivation behind this grandiosity, behind not sleeping, behind, why are you so excited about these things? When you think about that, it's all connected to this client's culture. So instead of me just slapping a diagnosis on this client because they fall under the DSM, it is our job to do a cultural formulation interview to make sure that we are accurately providing a correct diagnosis based on the rule out of cultural implications. All right. A client arrives for their appointment and instantly begins discussing why they chose to come to therapy and what their needs are from their therapist going forward. The therapist allows the client to finish and continues asking the client about their goals, level of commitment, frequency of services, fears, past experiences with therapy, and the top 3 things they want to work on going forward. We can deduct that this is what type of session? It is an initial interview. Again, they arrive for their appointment and they begin talking about why they want to come to therapy, what they're choosing, what their needs are. And then the therapist says, what are your goals? How committed are you? How frequent do you want to do services? Any fears, any past experiences with therapy? And what are some things you feel are your biggest 3 things that you need to work on in therapy? So that is an initial interview. All right, a therapist and client are well into their second session and have collected all relative information needed to fully support a client in developing treatment goals. Prior to developing treatment goals, the therapist should do the following. A, use all relative information to provide a formal diagnosis. B, discuss psychoeducation around the given diagnosis. C, ask the client if they are able to commit to therapy given their diagnosis and symptoms leads to inconsistencies in treatment. Offer advice around treatment goals. So I'll give you a little bit to think about that. All right. use all relative information to provide a formal diagnosis. So after session 2, you will take all the relative information and you will provide a diagnosis. You can go into developing treatment goals, but in order for you to develop treatment goals, you have to develop a diagnosis for this specific client. Now, discussing psychoeducation around the giving diagnosis, that would happen after you determine a diagnosis. So you can't create treatment goals for a client when there is not a diagnosis. Now, in respect to an exam. Now, there are going to be some clients that do not have formal diagnosis because you're not using insurance, so you're not required to provide a diagnosis for some of your clients. Again, according to the Texas Code of Ethics for professional counselors, you do have to have treatment goals for all of your clients, and you have to have records for them. So, you could have treatment goals for Z codes, for F codes, but you have to know what you're doing. And again, you'll get more into that as you get into practice, but for the sake of this test, you would provide a diagnosis first and then go into treatment goals. All right, how should a therapist conduct a mental status exam? So A, a formal mental status exam is no longer required. B, a mental status exam should be conducted after about 6 sessions of working with the client. C, within the first 1 to 2 sessions, and should include formal and informal observations and information collection to determine current mental status, or all of the above. Alrighty, it is C. Within the first 1 to 2 sessions, you want to know if your client is able to receive the information they're going to receive, if they're coherent, if they're oriented, if they have slurred speech. You're going to want to determine if they can tell you dates, times relative to today. You're going to want to make sure that they are appropriately dressed, whether or not, all the things that are in a mental status exam, you're going to want to do in the first 1 to 2 sessions. Because if not, if you have a client who has some enabling things that are showing up in the first 1 to 2 sessions, that is going to impact how you provide treatment. So that is important in the first 1 to 2 sessions. You wouldn't want to do a mental status exam in session 6 or beyond, because you technically should have done one informally or formally, depending on how your practice or organization requires you to do mental status exams, but you should have done one. Okay, a client comes in distraught with experiences of feeling overwhelmed, emotional pain, lonely, in denial, restless, worry, and fear of death. They shared that they recently lost their 4-year-old son to gun neighborhood violence. What provisional diagnosis could the therapist provide the client with? So A, prolonged grief disorder. B, postpartum depression. C, generalized anxiety disorder, or D, both A and C. I'll give you a little bit to think about this one. It will be both B and C. So this particular question is in alignment with assessing for co-occurring disorders. So this client is experiencing prolonged grief disorder, but they're also experiencing generalized anxiety disorder. Prolonged grief disorder is a new diagnosis, so that is in the DSM-5-TR. And so it wouldn't be postpartum depression because it's not following a miscarriage, it's not followed by a stillbirth, it's not followed by like a natural causes of death of loss. So it would be both A and C, because not only are they dealing with grief, they're also dealing with the anxiety and fear and worry around the loss of a loved one. A client comes in after a recent completion of an intensive outpatient program and shared that they had an incident that occurred yesterday that caused them to have experiences with a definite plan and intent to commit suicide. What level of care does this patient need? A, biweekly appointments to work on the intensity of the SI. B, admissions into a mental health facility because they have a plan and intent to harm. Referred for further assessment at a mental health hospital, or no additional level of care considerations are needed for this patient since they made it to the office safely. All right, the answer is B. So, of course, remember in the first video, I kind of talked about test taking skills and like the longest answers. There's 2 possible right answers, but which one is the most right? So technically you would refer them for further assessment at a mental health hospital. But since they have a definite plan and intent to commit, they need to be admitted into a hospital because they have a plan and they have an intent. The further assessment is, I want to do it and I have a plan and I'm going to do it with a plan and I have the intent to do it. So no further assessment needed per se, but a mental hospital is needed for this particular client. A 6-year-old struggling with anxiety around returning to school following COVID comes for therapy. Which of the following is an appropriate modality for treatment? A, cognitive behavioral therapy, B, gestalt therapy, C, play therapy, or D, motivational interviewing. All right, so the answer is C as in Charlie. So this is in relation to appropriate modality for treatment. Now, cognitive behavioral therapy would be great for anxiety. But for a 6-year-old, the modality may need to be play therapy. Now, both are right, but play therapy is most right because you are working with a 6-year-old client. Now, there is something called cognitive behavioral therapy, play therapy. It is a type of play therapy that could be used, or there is an integration of cognitive behavioral therapy in play therapy. But if you are working with a 6-year-old, you're most likely going to be using play therapy with a 6-year-old with some integration of CBT. But the emphasis is going to be on play therapy, and what you do in play therapy, you can add on to it. So the primary would be play therapy. A therapist tells a client, please provide me with a number on a scale of 1 to 10, with 10 being to the point in which you cannot function at your current level of anxiety, and 1 being where your level of anxiety has no impact on your functioning today. What is the therapist doing? A, checking in with their client. B, asking a client to provide their current level of distress with their anxiety using subjective units of distress. C, check in with the client on their level of distress. D, asking the client to provide their current mood in relation to their level of stress. And the answer is B as in boy. Now, B and C are both correct, but B is most correct. C, you're checking in with the client on their level of distress. Yes. But the most right answer is you're asking them to provide their level of distress with their anxiety using subjective units of distress. So subjective units of distress, if you don't know what that is, it is something to look into. You think about like the bell curve, you know how we used to have standard deviations. So that's basically what subjective units of distress. I'm trying to figure out how far off are you from stabilization in your functioning throughout the day. Does it have a huge impact on you? Kinda, and or does it have a huge impact on you and it is impacting your ability to get up, go to work, cook, clean, wash your clothes, brush your teeth, the things. All right. A global assessment of functioning can be used to assess an individual's level of mental health functioning. A, true. C, false. That should be B. It is true. Yes, a global assessment functioning can be used to assess an individual's level of mental health functioning. And so a global assessment of functioning is your GAF score. How is this client functioning in relation to their mental health? A client comes in with the diagnosis of depression, and they share that they are struggling with paying for food, They were recently evicted and are at their lowest point in their life, and they just need some help. The therapist begins to discuss with the patient's needs, and the therapist and client determines, in addition to psychotherapy, the client needs access to a community healthcare worker or case manager to support them in accessing additional resources in the community. The therapist was able to screen for appropriate services. A, true. That should be B. B, false. A, this is true. So yes, the therapist could have just bypassed all the issues that the client is having. But as clinicians, we treat the whole client. So we were assessing for additional appropriateness of services. So the subsection of, or the Section 2 of this exam, it aligns with screening clients for appropriateness for services. Now, this question or other questions in this particular subsection could just be, you have a client with an intellectual disability who presents at the age of 6, would play therapy be appropriate for this client or something of the nature? So it'll be in regard to maybe something like that as well. A client shares that they are sad, but they don't believe they have depression. The client does not want to believe they have depression and that they are only struggling with anxiety. What assessments can the therapist use to confirm or rule out a diagnosis of depression? A PHQ-9, B, a Hamilton Depression Rating Scale, C, Beck Depression Inventory 2, or D, all of the above. And it's going to be all of the above. So you can use a PHQ-9 screener to assess for depression. You can use a Hamilton Depression Rating Scale or a Beck Depression Inventory 2. Now, I think the Beck Depression Inventory 2 and the Hamilton Depression Rating Scale, I think those are both on the Pearson VUE website and can be purchased. But in relation to this exam, all of these can be used to either confirm a diagnosis of depression or rule out depression. Now, the PHQ-9 is a screener more so than a diagnostic evaluation or assessment tool. A parent requests the therapist to assess their child for ADHD. The therapist observes the client at school, requests Vanderbilt assessment scale forms to be completed, observe the child's behavior through play, and makes note of behaviors reported by the child in between sessions. Please select the most appropriate response in relation to the therapist. The therapist was able to collect data through formal and informal observations. The therapist acted unethically by attending the child's school for an observation. The client used the wrong assessment for ADHD diagnosis. The therapist should have been able to make a diagnosis using the DSM without following any of the steps they did. And it is A. So it would not be C, because Vanderbilt assessment scale forms are used for assessing for ADHD. Now, they are reports from teachers, a few teachers, usually a parent, and maybe another person that the client interacts with on a regular basis. So that's accurate. And you would also use formal and informal observations. The therapist acted unethically. Now, the parent did request ADHD. Now, there's no information that states whether or not they did a consent or a release of information. So again, it still has nothing to do with the question in relation to what the question is actually asking. A client shared that their mom forced them to attend therapy and shared that they don't know the real reason why their mom made them come. After continued discussion, you believe the client experienced trauma. What should the therapist do next? A, continue to play along with the client's surface level responses. B, cross off the idea that trauma was present altogether since they shared they don't know why they were forced to come to therapy. The therapist can terminate the session and refer them out because they didn't want to talk about their trauma. Or D, assess for trauma. All right, so here we're going to assess for trauma. Again, you wouldn't play along with the client per se, because in your code of ethics and your counseling skills, you are supposed to challenge your clients. Now, of course, not in a harmful way, but you are supposed to challenge your clients. So if they're like, I don't know what's going on, it's okay for you to challenge them about what's happening in their world and about maybe even statements that their parents reported. You can't cross off the idea that trauma was not present, because our job is to assess for trauma. That is a part of this is underneath the section 2 of assessing for trauma. And then C, you wouldn't want to terminate a client because they don't want to talk about something. Maybe they're not ready yet. So here you would just assess if there was some trauma. A client comes into the session with bloodshot eyes, shared they came to therapy to work on depression, and begins to share the reasons why their family has stopped talking to them. They shared their family was upset that they had been stealing from them. They don't like this new group of friends that they have. They started failing their college classes and have fears around their angry outbursts. What should the therapist assess for? Personality disorder, substance use, behavior-related disorder. Since they just met them, no further assessment is needed. You are going to assess for substance use. So if you understand the signs of substance use, you understand that these are the telltale signs that somebody is experiencing or is struggling with substance use. If they're stealing, if they're falling behind, failing their classes, if they suddenly have a new group of friends, if they have intense irritability or angry outbursts, they have bloodshot eyes, you're probably looking at substance use. Self-reports are questionnaires, tests, or surveys in which a client reports their symptoms, behaviors, beliefs, experiences, and attitudes. A, true, B, or C, B, false. This is true. So self-reports can be questionnaires. Self-reports can be tests. Self-reports can be surveys in which the client reports symptoms, behaviors, beliefs, experiences, or attitudes. So self-reports are a type of way of collecting data from your client. All right. A client shared that they have been having a hard time with maintaining friendships. The therapist begins to explore when relationship issues began to happen. They begin to explore the recurrent behaviors they exhibit and identify constant outcomes. The therapist is trying to do what? A, evaluating interactional dynamics. B, a diagnostic interview. C, help the client see where they are making mistakes. D, an initial interview. A. So they didn't determine if this was first, second, third, or fourth, fifth session. So it wouldn't be an initial interview. It's not a diagnostic interview because it's not asking intensity, history. Well, technically it is asking some of that information, but you're not diagnosing this client based on just their friendships. You will be looking at other things. Help the client see where they're making mistakes. Not necessarily. That could work, but not in this particular case. If that were the case, it would have some additional questions present. So it's A, evaluating interactional dynamics. So you would want to see how is this client doing or what's happening in all of their dynamics to help identify some of the issues that the client may be having. A therapist should only assess for suicide, homicide, self-harm, and relationship violence every fifth session, whether formally or informally. That is false. As a therapist, you're going to always assess for this. And you're not going to assess every 5 minutes in a session, but you're going to assess for it at the beginning of every session or throughout not the first session, but throughout each session that you have with this client. You may have a client that's doing just fine, but one day they came in and they were suicidal or they had done self-harm. So you're going to always assess for it. Because you are treating a client, it's your job to be aware of any potential issues that client may be experiencing. And your job is to make sure you help them through some things. Okay. A client shares that they are not sure as to whether or not they are making progress on a reduction of intensity with their symptoms. The therapist then provides them with a PHQ-9 assessment since their last one was completed. What is the therapist doing? A post-test, B, a formal evaluation, C, reverting back to old information, or D, rejecting the client session. And it is going to be a post-test. So here's the key. The client doesn't know if they're making progress. So that means at some point you may or may not have assessed the client's changes over time. The other thing is a PHQ-9 is not necessarily a formal evaluation. A Beck Depression Inventory is more so a formal evaluation, and it wouldn't just be one assessment or screener. It will be a compilation of things or observations for doing a formal observation or evaluation. You're not reverting back to old information. Now, you're going to compare old information to this new information to help have a healthy conversation with your client about their progress. So if you do a post-test so that you can provide them with hard data saying, hey, your first PHQ-9 that we did, which was our pre-test before I started seeing you, you reported this with the indication of severe symptoms or severe depression. Now, today, you are reporting that you have mild depression. So that's why it would be considered a post-test versus a formal evaluation, because it says that you're redoing a PHQ-9 since their last one was completed. All right, and the last question. A counselor should never evaluate for the effectiveness of their services. A, true. C, which would be B, false. All right, so it is false. You should always evaluate for the effectiveness of your services. Now, you might not do this every session, but every couple of sessions or at the end of every session, you may want to ask your clients, have I addressed your issues of concern? Do you feel like my approach was appropriate for today's session? Or over time, do you feel like I am meeting your needs? Do you think that someone else may better fit your needs or your support, or even just evaluating it yourself as a clinician? So that is our last question of section 2 of the NCE, intake, assessment, and diagnosis. So majority of this section should be easy to pass or to answer these questions because you are doing this in the field, or you did this in the field in practicum. So you're going to always assess, these are part of your basic counseling skills. So you're going to assess for effectiveness of services. You're going to assess for SI, HI, self-harm, relationship violence. You're going to use assessments to provide diagnosis to help you develop treatment plans. You're going to do a biopsychosocial interview. You're going to do a cultural formulation. You are going to do initial sessions or intakes. You are going to assess for substance use. These are all things you will have done in practicum. So this section shouldn't be too bad when you're answering questions on the NCE, but you want to make sure that you pull on that experience that you had out in the field. So whether you know anything about Freud, whether you know anything about all of the therapeutic techniques and which modalities, you know enough to know what you should implement, should not implement, and what assessments you need to pull and which ones you don't. All right. Don't forget to like and subscribe. I'll see you guys next time. You can find us on all of our social media platforms at Crave Counseling. So we're going to get into subsection 3 in the next video, and then we'll follow up with some practice exam questions in subsection in a follow-up video after that one. So if you have not watched the first video, watch the first video, watch the breakdown of that, then get into the questions, and then transition into this section and then keep going from there. So thank you guys for watching, and hopefully this video helps. I'm trying to make sure that they don't go past an hour, but answering these questions and like actually breaking down how to answer the questions is what I try to do. I didn't do it in all the questions, but hopefully me talking through some of the kind of helps.